We're going to start first with the live case because I understand they're ready. Hi, Fadi. Can you hear us okay?
Oh, we're going live. Hey, good morning, Serini. How are you?
Good, good. Tell us what's happening.
Well, we thought we have 15 more minutes, but you know what? Perfect timing. That's perfectly fine.
Fadi, so, Fadi, we can do one or two talks and come back to you because you're live on the screen.
No. This is actually perfect. So,
okay.
Thank you for inviting us. Good morning, everybody. My name is Fadi Saab. I'm an interventional cardiologist here at Michigan Outpatient Vascular Institute. Thank you for organizers for inviting us. We're happy to be sharing our cases with you today. I'm accompanied today by some of my colleagues, our CLI team. To my right is our interventional mid-level provider, Andrew Kozak, very talented. And we have Shadi, who is our nurse that's going to be assisting us today. To my left is our interventional ultrasonographer, Caitlin. And in the back, we have Ricardo, who's monitoring the case. And I want to thank our industry supporters for being with us here today. Can I have the slides, please? All right, so this is our case presentation here. This is a patient in their 40s, unfortunate. And actually, this is I think it's a good case for some discussion in terms of a clinical presentation. This patient has a history of critical limb ischemia with rest pain on the right lower extremity and rest pain on the left lower extremity, was treated last year, has multiple risk factors, the typical risk factors that you see with the CLI patients. Can I have a blade, Andrew, please? We treated her for rest pain actually in the right leg, and the patient started developing claudication symptoms in the left leg. So it begs, the discussion. If you're a CLI patient, does your threshold for treatment change with claudication or not? And if you're a CLI patient, are you always considered a CLI patient, or you can be downgraded to claudication? So we have an interesting clinical presentation, but also the patient was found to have an occluded superficial femoral artery with possible tibial disease. We will see if we need to. We'll share with you that information. We're starting with antegrade access in the left common femoral artery under ultrasound guidance. And we're going to take some pictures, so that's what I meant by it's a perfect timing. Can you show the next slide, please? I want to show you the ultrasound and what it shows. And actually, we have Kaylin, our interventional ultrasonographer. We'll do an angiographic image first, and then we'll show you what we have with ultrasound. So I'll stop here and see if you have any questions, Serini.
Okay, great. Thanks, Fadi. Great intro. Just want to tell you who we have this morning. We've got Christian Bianchi. We've got some experts in the room. George Crescent, Brian D. Robertus, Sanjay Desai, Stephen Coombe, Sahil, I think, is here. Sahil Parikh. Sahil is here. And Raman Sharma, of course, one of our directors here. So any comments from the panel at this point, or do you want to see the angio, I assume?
I would like to know,
sure.
A 40-year-old is a little bit young.
We do have one question, Fadi, while you're taking your pictures.
In terms of clinical presentation, does she have any either genetic or vasculitis or other
We're not on DSC.
risk factors for accelerated atherosclerotic disease? And number two, why endovascular interventions were entertaining a young patient versus a more longer, durable intervention?
Could you hear that, Fadi?
Yeah, so those are all great questions. So unfortunately, this patient has a long-standing history of hypertension and diabetes since her 20s. She's African American in our area here. Unfortunately, this is a common occurrence. Her venous conduits are not ideal. They're for bypass. They have been looked at, and you can see the issue here, right? So. The vessel itself is extremely small. That does not exclude the possibility of bypass surgery in general. So, but is that the question? Is why this patient is not being sent to surgery before endovascular therapy?
Yeah, I think the question was, given the young age, the multiple interventions, at this point, do you look at alternative treatment strategies that are, might be considered more durable, I would think. Any of the surgeons on the panel want to comment? Christian, Brian, Stephen, anyone?
So if there's no venous conduit or adequate venous conduit, I should say, would you still entertain surgical approach first?
Hi, Fadi, this is Brian DeRobertis. I do a lot of these interventions on people this young as well who have very advanced diabetes and hypertension. It's unfortunate how aggressive some of the disease patterns we see is in certain areas. I will say, I think you already pointed out the small size of these vessels. My experience has been that with patients that have vessels that are quite this small, there are often no good endovascular solutions. I don't think putting stents in vessels that are 4 or 5 millimeters in diameter are very effective. And I think there's probably a very high likelihood of failure of any type. That just makes looking for an open option that could be more durable all that much more important. Again, it depends on whether or not you have conduit. If you don't have saphenous vein, I certainly wouldn't be an advocate of doing PTFE grafts over an endovascular intervention. But I think Christian's point is very well made. I think if there's a surgical option, that's probably the best option for this patient, especially since she seems to have 3-vessel runoff distally. And that would suggest she'll have a good bypass.
If there's no venous conduit, would you still entertain bypass surgery? I guess that's what I want our surgical colleagues to comment on.
Well, you can use cryovein, for example. I mean, if this is a 40-year-old and you don't have autogenous ipsilateral, you can also go arms. Maybe she doesn't have that
command
either.
wire open, please.
You can do cryovein as well. So there are always options.
Which wire do you want? Sorry.
Command.
Yeah,
So you would consider a cryovein before endovascular therapy?
Yeah, in a vessel that is a 4-millimeter vessel, yeah, for sure.
Okay.
How big is that SFA, Fadi? Do we have a measurement? I don't think we had a measurement.
Is our sheath into it? Yeah, so that's, are you guys showing? Yeah, you're showing the ultrasound. So we're going to show you we're going to measure it in the short axis view, and then we're going to measure it in the long axis view. So Caitlin, can you give us a short axis view measurement?
The SFA?
Yeah.
Fadi, this is Stephen. Good morning to you. Thanks for putting this case up. I was just wondering, any point along the way, could you give us a blowback angiogram of the inflow, just to have a look at the common femoral and the iliacs, if you could shoot that contrast a little bit more, because I think we didn't see the common femoral at all on the angiogram.
So this was an integrated access, Stephen, but we know with her arterial duplex, there was no evidence of inflow disease. For the patient. She does have inflow disease on the right side, but no inflow disease on the left side. No high velocities in the common femoral artery. So that's why probably the angiogram did not show ideal cases. Yeah.
And to me, clinically, when they have just SFA disease, rest pain, it's not very clearly explained. Is that normal profunda, you have already fixed the inflow, or she has normal inflow. Clinically, I will say to my patients when they have rest pain, maybe you have a mix of neuropathy, diabetic neuropathy plus vascular insufficiency. I'll address the vascular insufficiency component. You may still have some residual things. So rest pain is a little bit of a difficult endpoint to chat.
I'm in the branch.
And it has to be long life, too. It's not like tissue loss. You have to heal a wound, and then the patency becomes a hemodynamic endpoint, not just a clinical endpoint as much. So, yeah, challenging patients, rest pain.
Maybe Brian, Stephen, Christian, or anyone else on the panel. Could you guys comment on what you tell patients in terms of primary patency of synthetic FemPop, above knee bypass versus cryo, preserved vein? What do you typically tell patients?
Still in the branch.
What to expect?
I mean,
for us
for prosthetic bypass, I think it's just an option that when you don't have an endovascular approach, when you're going that, cryo is an expensive proposition. So we don't usually use it in occlusive disease as an alternative conduit. Maybe the infected fields additionally. But for this particular case, a 40-year-old that you're talking about an outcome of 20 years, I think it's certainly worth considering.
I think also it's worth pointing out a fem above knee pop bypass has a patency about equivalent to vein. So I don't think I mentioned I wouldn't do prosthetic. I would probably do endovascular here because of this. If you had a lack of conduit, but the truth is, a fem-pop above knee with PTFE has one main disadvantage in my mind, is that when they clot off, when they go down, they often will take out some of the artery with them, which vein grafts don't do. But the patency rates on those are actually pretty good. So a fem above knee pop is not something I would shy away from with PTFE. The problem I've had with cryo is, it's expensive, like you said, but also it's they tend to reject over time. So those really, in my experience, don't last more than a year or so. So that's not a great long-term solution either, I think. But I think.
May I ask what the audience think about options such as the PQ bypass? If we're considering PTFE already, would you consider doing an endovascular approach with a system like the PQ bypass?
Yeah, that's a great question,
Detour.
Fadi. What do you guys think, PTAB versus, the traditional open
Let's
bypass?
map this, Andrew. Let's map it.
Do we have enough data at this point?
Want to road map
Obviously.
it?
Yeah.
Okay, so you're going to do it on
Christian,
venous side. You have to
Steven,
step on the fluoro side, then
Brian.
shoot it.
Okay.
Anyone?
Yeah, I don't know that I would go to that right off.
Wait till it turns black. Now we got it.
I think going right off
Let me
off
have
the
the command
bat,
wire.
I think
Oh,
right to
unfortunately,
the
it's on
PTAB
the
is a little
left
bit
pedal, okay. Just the
aggressive.
fluoro
I think
pedal down.
unfortunately
Okay.
after the
That's your
initial
command wire.
angiogram, you
Introducer.
see
I'm sorry?
a diameter
Introducer,
of 4 millimeters or so. That's going to portend poor outcomes.
Yeah.
No matter which way you go.
And I think we saw that right from the Kumar's talk yesterday as well. I mean, you really want a nice proximal SFA stump and a distal landing zone, as we all know, and a 10 millimeter, femoral vein as well, right? So,
And I think that procedure is always going to have trouble getting traction among surgeons because of the fact that you're, just to avoid a couple incisions, PTFE fem-pop bypass is something with two incisions about this big, and that's not something I'm going to avoid in favor of going through a femoral vein that could be then become obliterated over time. So I think if you don't have if you have a reason not to do a surgery, bad coronary disease, wanting to avoid the general anesthesia, then I suppose it's reasonable. But I think for most surgeons, that's going to be a hard sell.
Yeah,
and that's what most of the surgeons that I know and work with tell me the same thing, Brian. Exactly what you said.
well, and a long
Can you hold the catheter there,
length covered stent. I mean, that would be extremely hopeful to think that that's going to last a long time.
We've done a few of these PTABs already, but we haven't seen the failure of them and then requiring a re-intervention. From a surgical perspective, does the presence of the
Thank you.
PQ bypass make a fem-pop bypass down the road, open surgical, a little bit more challenging?
I don't think so. I think there's still probably a salvage option for a bypass down the road. I guess it kind of depends where you go in and go out. If you're coming off the proximal SFA, that's not a problem. We don't generally base bypasses off the SFA. We always do the common femoral,
Andrew,
almost
turn it
always.
clockwise for me.
Sure.
Distally, it could impact your distal target.
So maybe, Fadi, while you're working right now, if you save some good images, we'll have you live on the screen. Do you mind if we go to one or two talks while you're working?
Yeah, go ahead, guys. I think if I remember correctly, the case keeps playing while you guys are doing the talks, right?
Yeah, it should.
Or no?
Yeah.
Okay, please.
Okay.
Right now, we just engaged the proximal cap. I have a command wire with a spec 035 catheter. And we're going to try to continue to cross this under ultrasound guidance. If we're not successful in an integrate fashion, we're going to access one of the tibial vessels and go in a retrograde approach. But
Okay.
please go ahead,
Yeah.
and we'll get back to you.
Please interrupt us when you're at a good spot, too, if you see something interesting. Thank you. Fadi, can we go to the live case, maybe? Hi, Fadi.
Hey, Serini. So we noticed with ultrasound that our catheter went subintimal just after the proximal cap. So we made the decision to, can you go back to with the saved ones? So we made a decision to get tibial access. We accessed the posterior tibial artery. We advanced the V18 wire with a CXI 018 catheter. And you see in the saved images live, this is how fast we crossed the distal cap all the way. And now we're at a point where we're trying to basically marry the integrate catheter with the retrograde catheter, and that's where we are. My interventional ultrasonographer tells me that my retrograde wire is in a good spot. and we want to see how far we need to pull back our antegrade catheter. We're in the true lumen. So our goal is to cross true to true, especially in this scenario here. So that's our objective. So I don't know if you can see the ultrasound image.
Yes, we see it.
Okay, so this is the antegrade one or the retrograde? It's probably retrograde. I'm wiggling, so it's not moving. So that's our retrograde wire and catheter. So we're going to show you under fluoro how these wires are interacting. Caitlin, you might push the wire from below.
So Fadi, we have about 75 fellows, so maybe we could just go over a few basics on your pedal access. Do you have a 2.9 French sheath, pedal sheath, and did you give any type of cocktail? And what catheter and guide wire system are you using? I think CXI V18.
You know me, Serini. Okay, that's beautiful. Very nice. So I don't know if you saw that, but the minute you said fellows, the wire jumped in. This is the tunneling technique. So we typically, I believe in placing low-profile sheaths to protect the arteriotomy site in the foot for a lot of those patients. So it's a 2.9 French sheath from Cook. There's other options from other manufacturers. Can you disconnect? Can you remove the wire now, Andrew?
You want what?
Remove the wire. There's other manufacturers, but low-profile sheath. This is an 018 CXI catheter. It's also made by Cook. It accommodates 018 equipment. And what you see right now is an antegrade 035 wire, the spec catheter. Go ahead, Kaylin, advance. Can you give that wire to Kaylin, please?
Yes.
Basically, we inserted the 018 catheter inside the 035 catheter from above. Now, I would like to point out one important thing here is the fact that the second we got subintimal,
This is the front end.
we proceeded with antegrade access. And I intentionally wanted to show this because, honestly, if I was doing this case, I would start with pedal access. Because of the morphology of CTO cap, it was really not favorable for antegrade crossing based on the CTOP trial.
Got some resistance.
And if the fellows are interested, this is a paper that talks about CTO cap morphology. You can advance the CXI. Can we open an IVUS, please, and turn on the laser and open a catheter?
It's all
1.7.
buried, the catheter.
So right now what we're doing, Serini, is we have a command wire, 014 wire, that was advanced from the pedal axis all the way to the column femoral artery axis. We are going to maintain, that's it, that's good. And go ahead, remove this catheter over the wire. We are going to maintain the floss system. We're going to start with intravascular ultrasound to assess the size of the vessel and what modality of revascularization we're going to utilize here to treat this patient. My approach, my strategy in this case is to avoid the placement of any self-expanding stent simply because of the size of the vessel, and I think that was very eloquently pointed out by your audience, by your faculty there, and I agree with that. Simply because if the patient would require any surgical intervention in the future, we want to avoid placement of a stent. I think the stents perform very poorly in vessels less than 4 millimeters. I don't know what the co-panelists think.
They're
and
in
I'll stop
agreement.
here. Do you have any questions?
Yeah, everybody agreed. Any questions from our panelists at this point? Anything you would do differently? I think they want to see the IVUS. They're ready.
Yeah, so we just have the IVUS going in right now. There. Are you guys able to, yeah, I see. You have the feed for the IVUS. ACT in the back. So, Serini, as you know, the data and the outcomes with utilization of IVUS, especially in CLI patients, have been to show benefit in those patients. And I think it's it's important to point out, like, for a modality to show benefit, it's extremely difficult. So I think, in my humble opinion, okay, ring down, thank you. In my humble opinion, IVUS should be a mainstay of evaluation in these cases. So we're starting here in the SFA, and you can see 1 to maybe 3.5 millimeters. We are in the CTO, but it looks like we're in the true lumen. And for the fellows, the way I know that we're in the true lumen, you can see the echogenic intima, then the hypoechogenic media because of high water content, and then you see the adventitia around it. And we're advancing slowly. We're trying to see.
Yes.
1.7, yes, please. Okay, so this is an important picture because what you see between 9 o'clock and 2 o'clock is basically my subintimal antegrade dissection. And I already added 2 millimeters to the vessel, not added, but you know, I already created basically a hematoma because of the antegrade dissection. So the argument against early pedal access in some of those cases, I think, you know, the more I do IVUS, the more I realize, like, you know, we need to really assess these CTOs and approach them based on their cap morphology. So when we realized we're subintimal, we stopped. So it's about 2 centimeters or so. And you can see why the vessel is just too small. You know, 3 millimeters. Obviously, there is some component of negative remodeling. So we are still in the true lumen of the vessel, as you can see. I'm just commenting on the findings. Serini, please interrupt me at any point if there's any questions, but this is kind of what I see. And now this is a reconstitution portion, and we're in the popliteal, or maybe distal SFA, sorry. And you can see the vessel size is maybe about 4 millimeters. And you can see the vein, by the way, you can see the vein next to it. You know, for PQ bypass, and again, I'm not advocating for PQ bypass, but, you know, I heard the comment about the veins being occluded. You know, the trial did not show that. You know, they followed those patients for 2 years, and the rate of DVT was severely low, very low for those patients. Obviously, I'm not advocating this just for one patient. You need to choose the right patient, but, you know, that's a major concern for a lot of physicians in terms of what happens with the venous system. All right, so we are at the PT there. I'm sorry, that was the TPT, sorry. And then this is the PT here. Yeah, so this is kind of the image that we see with patients with, you know, risk factors, young, history. By the way, there was a history of smoking also. You see these small vessels, kind of thrombotic, fibroelastic, and not a lot of the typical, you know, calcific atheroma that you see with those patients. That's common in this patient population. I'm curious what other panelists think
Maybe
with their patient population.
Maybe I'll get them to weigh in. So, you know, based on what everybody's seeing here, would most of you proceed with endovascular treatment? I mean, we've already crossed at this point, and then what's the plan afterward?
CT is 140.
Or would you stop and
140.
140.
have a discussion about surgery like we had at the beginning?
She needs wire.
Is your mic on? Or-
It's good. Let me have a seat.
Can we turn on the mics on the?
Yeah, is this on now? Okay. Yeah, I think with the long-term
4
problem
by
here
240
is
balloon,
medical, because you're constrained right now by
140.
small anatomy. You're constrained by the fact that the vessels are already, you know, fairly angry because you have repeat procedures. So long-term, the main problems here are medical. I mean, if the diabetes isn't well managed, if you don't come up with the right antiplatelet, antithrombotic regimen, then this is all headed, you know, in the wrong direction long-term. And I think that's the struggle here is, there's not really going to be a right answer for long term because of the inherent problems we have here
No, that's
anatomically
good the
and
way it
medically.
is.
So maybe a show of hands, would everybody just proceed with therapy right now? And if so, what would be your vessel prep? I mean, I think we have an idea already based on the sound, but I think would most of you proceed with laser at this point or any other type of vessel prep?
I usually use.
It's reasonable. That's very reasonable. It's reasonable to debulk this, and I'm assuming that DCB is going to be the next step. But again, there's no right answer here for sure.
I think another consideration would be to try some form of atherotomy, whether it's with a serenator or a chocolate balloon, something to just do a little bit less damage to an already angry vessel that's been multiply intervened upon.
Buddy, could you tell us what treatment was offered to the patient the last time round you had an intervention in the index leg?
The last time the patient was treated, she was treated with, I believe, a DCB in both lower extremities.
And this is the left leg, so I think last treatment was 2023, Fadi, right?
Correct. The patient was treated with DCB in I believe, in both lower extremities. I don't recall the size of the balloon. I apologize, but that was the modality that was utilized. Stop there, please. Let's bring the catheter back and do another run. One of the comments was about stop there, Andrew. One of the comments was about using specialty balloons, but what caught my ear was you wanna make sure that you're not irritating the vessel, and utilizing plaque modification allows you to use low pressure balloon angioplasty, and that was evident in all the trials and all atherectomy devices comparing the atherectomy arm to the balloon angioplasty arm, because you don't have to go with high atmospheric pressures for these vessels to yield. So I mean, I would argue that barotrauma in these vessels after plaque modification, albeit shockwave, albeit atherectomy, allows you to avoid these mechanical complications if necessary.
Fadi,
Please.
for those who are learning, can you talk about your technique with the laser? What brand, what settings that you typically do, SFA, tibial, etc.?
Right. So this is a great question. This is actually where IVUS matters, right? So we have a 3.5 4mm vessel in the stenotic area. So there's negative remodeling. And then you have the vessel appears to be about 4.5mm in the areas that are relatively normal. Because of the nature of a plaque morphology here, I chose laser to modify this fibroelastic atheroma. Because the vessel is small, I used a 1.7mm vessel, Phillips vessel. There's other laser types. I usually use this type of laser. There's a fluency, there's a rate, and there's fluency. Fluency refers to the power of the laser device, and rate refers to almost a jackhammer effect, applying that force to the walls of the vessel. There's three mechanisms of actions when you're utilizing laser. There's mechanical, photochemical, and the most important thing I think with laser is advancing it slowly. Let's do the ultrasound. So I want to stop, please. I want to show our fellows at least something that's very important, because whenever you do like a training with laser and they show you the bubble in these videos, I want to show you under ultrasound how these bubbles form. And when you move fast, you actually lose the effect of the laser. Let's activate it there, Andrew.
Activate.
So right there, what I'm going to do, I'm going to increase the fluency and the power. Stop there. Can you go up to 60, 40, please? And I'm in a relatively open segment, so I think I'm safe to do that. Activate, please. So are you able to see the cavitation created by the laser,
Yes.
Serini?
Yes.
So if I move fast, you basically lose that effect. Versus if you're moving slow, you're impacting that plaque. And really that goes to the point of, stop. That goes to the point of, let's add the balloon now, of how to utilize each atherectomy device. Not all atherectomy is created equal, and not, in my opinion, not all devices behave the same way because it really depends on the center experience and the operator experience. So understanding how these devices work, no matter what it is, DCB, specialty balloons, atherectomy, stents, you'll be able to get the best results out of it.
So
Right
what's,
now,
what's
I
your,
have
what's
chosen,
your plan? What's your plan now, Fadi, at this point?
I have chosen a 4.0 by 200 millimeter regular balloon. I would like to treat it, and then if we need to use a DCB, we can choose a DCB after. But I typically use DCB as an accessory therapy in the sense that I don't think of it as balloon angioplasty. I think of it as a tool to deliver the drug to the walls of the vessel.
Okay. Would anybody do anything different at this point? Any comments from that?
I just think that the main thing I would do in this scenario is to, if I'm intervening, is to avoid dissections or the need for stenting, more stenting than is necessary, because I just don't think a stent is going to be ideal here. And if I did have to stent here, I would try to do it in a limited fashion.
2 atmospheres.
But
One,
I think
two, up at 2.
use of DCB here is
Clock's
critical to avoid restenosis and hopefully not have this patient come back with the same problem, and trying to think down for future options so that you don't burn a bypass option, for example.
So here's a controversial, maybe controversial. You know, DCBs. Why do we think DCBs failed in the tibial vessels, and they showed benefit in the suprapopliteal segments? And one of the arguments is the size of these vessels. So would you say that maybe DCB is not going to perform as well in these small diameter vessels? That's to me, that's maybe an academic discussion, but an interesting point that I would like your input on.
Anyone?
3-4.
3-4.
George,
One up at
Sahil.
4.
Well, I think
Three.
Sahil chime in,
And
but I
4.
mean,
Yeah. Since that's going to be his talk, too.
when you're less than 5 millimeters, we know that any sort of metal's not going to work. So essentially, DCB is going to have an advantage there just because you're not leaving behind a bunch of small diameter metal.
I mean, the thought is rational in that there's a fixed amount of late loss that occurs irrespective of diameter of vessel.
Giving
So
200 of
the
nitro.
late loss
200
with
amount.
DCB is usually close to 1 millimeter. So if you have a 4 millimeter vessel, you'll wind up with a 2 millimeter lumen when you think about 360 degrees. On the other hand, if you don't use a drug, the late loss is going to be occlusive. So you don't really have a lot of choices. Small vessels don't behave well. The
Sorry,
ability
Juan,
to
just a
reduce
little one. It's
late
gonna go in a
loss
second,
even
okay?
more is possible with stents and with greater drug delivery. And I agree with Brian that if you can avoid a scaffold here, you're better off because the amount of late loss that's induced by the mechanical disruption with a stent is greater. So, but I think that it's absolutely compulsory to use drug elution in a technique, in a case like this. And the downside of stent failure in this small vessel is greater than probably balloon restenosis.
I would also just echo, I think what Sahil explained about late lumen loss is a reason why, in my opinion, DCBs will never work as well in the tibials as they will in the SFA, but it doesn't mean they don't work. And it doesn't mean that, the prior trials that have failed may have failed for various reasons, some of which may be efficacy, some of which may have been trial design and endpoint. So I don't think we've seen the end of drug elution, even without scaffolds in the tibials.
And the other point is that not all DCBs are created equal. You know, I think we tend to categorize them as a class effect, but that's not true, I don't think, scientifically.
Great. So maybe, Fadi, while you're working here, we'll go to one or two more talks and come back to you, if that's okay?
Yeah, thank you.
Okay, all right. So maybe we'll check in with Fadi if he has time.
Can you hear me, Srini?
Yes.
All right, so can you play the last? I want to show you, so we did the prolonged inflation with our regular balloon, the 4O balloon, at 4 atmospheres, at 6 atmospheres. And there is a couple of areas that I'm questioning. Obviously, the one on the top is the most evident one. So what I decided to do is actually do a run of IVUS. So can we play the IVUS run, please? Thank you. So I am paying the price for not starting with pedal access in this patient. So you can see that the dissection, the antegrade dissection. But then actually the rest of the vessel looks reasonable. Remember, it's a 3.5 millimeter vessel when we started. And then there's a dissection there's a dissection right there. So what I'm going to do is actually we switch to a 6 French sheath, and we placed a DCB balloon 4O by 200. And we're going to go with high inflation, well, not high inflation, but we're going to go at 10 atmospheres, because I think the vessel is starting to kind of relax a little bit. We're getting 4.5 to almost 5 millimeters in distal areas. So I want to avoid stenting here at all costs, even that area of dissection. But after I saw it on IVUS, I'm not as concerned. This is the angiogram after the first balloon angioplasty. Do you have the next one, Andrew? Let's see, show the one after this one.
That's that. That was the one.
Yeah. This is the one after the second balloon angioplasty, and that's when I IVUS there. Any questions?
Thoughts? Anybody on the panel?
I'm not quite sure I understood correctly. So did we increase the atmospheres to manage the dissection, or we increase the time of balloon angioplasty to manage the dissection?
Both.
Anybody do
Both.
anything
We increase
different?
the atmospheric
Sahil?
pressure and the duration.
Yeah, it's a tough case, Fadi, for sure. So your plan now is to do DCB, obviously, correct?
That's what we have right now. That's the balloon that we have right now is DCB. So, the data with dissections and DCB is actually pretty reasonable because the drug is penetrating. I mean, these are the cases that you would expect DCB to work very nicely because there's not a lot of calcium. And I usually, most of the trials recommended 3 minutes. I usually go as long as my patience allows, but no less than 3 minutes. So we're gonna do 30 more seconds here and then give you a picture. Can I have a Minx, guys, please?
Okay, maybe while we're waiting.
And show you the final images. In terms of, for the fellows, in terms of management of the pedal axis, what we do is actually ultrasound-mediated closure of the pedal axis. So we're using the hockey stick probe. Our interventional ultrasonographer would apply modulated pressure on the access point, allowing antegrade blood flow to the ankle without bleeding outside. So we avoid actually, inadvertently shutting down the vessel. And since we've followed this strategy, we haven't had, knock on wood, we haven't had any episodes of acute closure within these tibial vessels, especially with the 2.9 French sheaths. 5 French minks, yes, it's 5 French.
100%.
What does the panel think? I mean, we have 2 areas of dissection. We have some lumen loss at those 2 sites. What if it looks the same after this?
We don't have any 5.
What should we do?
I need a 5 to.
Wait.
And Fadi, which drug-coated balloon did you use?
6 outer. Yeah, you can still put it in.
I use the Philips drug-coated balloon,
Stellarex.
paclitaxel,
Yeah.
Stellarex.
Yeah. So, I mean, I think that my personal feeling is that this is a question of, is perfect the enemy of good enough? Small vessel, if you're going to scaffold with any kind of standard nitinol stent, you're going to have a sort of a never-ending cycle of restenosis. Even Supera here, I wouldn't necessarily be excited about since it's so small. And the flow is pretty good, but I think you're going to expect that you're going to have a TLR at that second dissection or that proximal underexpanded segment with a dissection. And if you do aggressive surveillance, you may be able to come back and do it, what our surgical colleagues call assisted patency with a touch-up angioplasty more easily than if you're going to do something else. But this young woman, it's going to be a never-ending cycle of repeat revascularization.
Is there any worry about acute or subacute closure with the dissection?
I think if you keep her on adequate antiplatelet and anticoagulant therapy, she probably should be on dual pathway inhibition. Probably not. But, you saw on the chroma flow there wasn't a very deep dissection.
I mean, we all remember the Bolia paper back then, and the result of balloon angioplasty was significant non-flow limiting dissection, some pictures that look awful, and the patient did fine. So I think what I would say is, stay away from harm, encourage this patient to a very aggressive change in lifestyle and physical performance to avoid recurrent clinical rest pain, and maybe address neuropathic component as well.
But I think this is the poster example for antiplatelet and antithrombotic.
Yeah, dual pathway inhibition for sure. What's your plan now, Fadi? We saw your angiogram that you just did.
So usually with these small vessels, I like to use external compression closure devices for integrated access. I don't use any devices with active fixation inside of a vessel because that's a recipe for a complication, unfortunately. So I'm using a Minx closure device. You can use the Vascade, they're external devices. I usually marry that with external compression. And one advantage to having our interventional ultrasonographer with us here is we never take the patient off the table without confirming hemostasis with ultrasound. It's okay. Hold on, Andrew. Just inflate it slowly. Okay. Don't inflate it anymore. So when the vessel is small, these again for our fellows, these balloons are 6 millimeters in diameter. So you want to avoid inflating them completely in small vessels. So what I do is I fill it with contrast, and I slowly start pulling back the sheath under fluoroscopic guidance. A little bit more, Andrew. Okay, stop there. So I want to show you, see how the balloon is like straight on both sides? It's larger than the vessel, so go down a little bit. So I'm going to go down. I'm not going to tug on the vessel. I don't want to create barrier trauma. So I keep pulling on my sheath until I get into the common femoral inflate there. Down a little bit.
Down.
Just a little bit. More now. Inflate it.
Going up.
Inflate it. Down a little bit.
Down.
More.
More down.
Inflate it.
Inflated.
Okay. So now I feel the balloon is free. I take it to the arteriotomy site, and this is something I do. I inject contrast to essentially see that there's extravasation outside the vessel. So I am confident that I am deploying the closure device outside the vessel and not inside the vessel. Just gently push down a little bit, Andrew. So that's an important trick here because, we don't want to create a cold foot here. And unfortunately, that's something that I've seen happen in the past. So now I follow the recommended instructions by the manufacturer, 30 seconds of gentle pressure. And if you actually notice, I actually keep the pedal axis, the 2.9 French sheath. And the reason I keep it is because, you can relax your hand now. The reason I keep it is because, God forbid, there's an issue or a problem, we have access to tamponade the access site. So it's another safety mechanism for those patients. All right, so this is our case. We have, hopefully everybody enjoyed the discussion and pros and cons. And we have another interesting case, a little bit different. I would say a lot different. And hopefully we generate more discussion. Thanks again for inviting us, and congratulations on another exciting year.
Thanks, Fadi. Thank you very much. Appreciate you and your team. And